So as you know, we'll be hearing from Dr. Michelle Barton and Dr. Alex Summers tonight, and can field questions as well. So I'll pass it next to Dr. Vineet Nair, who will introduce the Southwest Primary Care Alliance.
Thanks, Natalie. No, sorry, we've got a next Jen. You can just go back to the agenda there. That'd be great. Thanks. Yeah, no, we've got a pretty jam-packed session tonight with lots of interesting information, and lots of things are moving fast and furious as they have been all last 2 years. It seems like for all things COVID. We're going to have a presentation from Dr. Summers talking about the Middlesex-London Health Unit updates, which again, lots going on with that. And then Dr. Michelle Barton-Forbes will be talking about vaccinating children ages 5 to 11. And then we'll have some more time for questions and answers at the end of that session too. So please feel free to ask questions in the chat, and we'll try to answer them during their talks as well. But if we don't get a time, then we'll hopefully have time at the end of the session to answer those questions then. So again, our first section of this presentation is Dr. Alex Summers. So as Dr. Barton-Forbes called him when they arrived this evening, that he's the most famous man in London right now, most popular man in London right now. So there you go. I think everybody knows who he is. He's our acting medical officer of health, and he's been helping guide us through this pandemic impeccably over this past 2 years. So I really appreciate his Tuesday updates and another update at our town hall. So Alex, thank you very much.
You're welcome, Vineet, and good evening, everyone. As always, a delight to be with you to talk about, just an amazingly exciting time. We are actually vaccinating kids, and that is just the coolest. So hopefully you can see my screen okay, and hopefully you can hear me okay. Vineet, are you hearing me all right?
You're good, Alex. We can hear you great.
Perfect, and that way I'll get into it. I'll also note Michelle is on, and it's just a delight to be able to talk with Michelle around vaccination of children 5 to 11. I will note, Michelle and I have been working fast, so I'm sure there may be some duplication in terms of things we're talking about. So Michelle, if I'm going into things that you are going to cover in depth, please just let me know. We'll go from there. But let's to it. So firstly, on Friday, we started at the Middlesex-London Health Unit vaccinating kids 5 to 11 years of age. We're starting in the mass vaccination clinics, and we'll be starting to move forward to do a little bit more in the community starting in January. We'll get into those details in a bit, but it has been a really great and successful first couple of days for us. We've had almost 25% of the eligible population already book vaccines. Most of those will be done over the course of the next week and a bit. And our objective really is to get that 50 to 60% vaccinated by the end of December. Given that that's the group that we think is going to be willing to get vaccinated. The vaccine has made a huge impact on our overall COVID response. It's hard to underestimate how impactful this vaccine has been. I want to just give a quick highlight of the overall impact of the vaccine on our efforts to date. And then we'll talk specifically about 5 to 11-year-olds just as a quick highlight. And then obviously, Michelle will get into further details. This is from Public Health Ontario. They do an enhanced EPI summary, looking at kind of a week-by-week basis at what's happening for COVID-19 following vaccination in Ontario. And I just want to give you a quick highlight. The big summary from this report is that COVID vaccine effectiveness continues as it stands. And obviously, we'll talk about Omicron at the end. But as it stands, vaccine effectiveness is estimated to be greater than 85% following 2 doses, and that's been remarkably consistent. While the cases certainly do occur following vaccination, and we've seen some of those recently, including at Western in the Saugeen Maitland residence, there's evidence that the vaccine reduces symptomatic infection, the severity of illness, as well as transmission. And notably, vaccine prevents serious outcomes. This is not a surprise to you at all. Some preprint data that we've seen just recently from Jeff Kwong with ICES, looking at the ongoing effectiveness of both Pfizer and Moderna in Ontario, suggests a sustainable protective response. And this is one of the reasons why we are, I think, seeing a bit of a different Delta wave here in Ontario. On the left-hand side, this looks at vaccine effectiveness over time. The red line is hospitalization or death. The yellow line, symptomatic infection. The blue line, any infection. And as you can see on the x-axis, we go from 7 to 59 days, 60 to 120, all the way out to greater than 240 days since you received your second dose. And what you really can see both for Moderna and for Pfizer is that the protection against hospitalization and death is maintained north of 90% for both of those vaccines, even greater than 8 months out from your second dose. Symptomatic infection does dip a little bit, but not dramatically in Ontario, and likely that's due to the delayed second dose for many people. Moderna does seem to dip a little bit, and that might be because of the population that was vaccinated with Moderna at the time, not entirely sure. And then any infection, it does dip a little bit, but it's still north of 70%, 8 months out here in Ontario. So we're getting sustained, ongoing, powerful protection from both of these Pfizer and Moderna vaccines here in Ontario. And that's something to celebrate, to say the least. The other highlights from this report from PHO, just highlighting that since the COVID vaccination program began almost a year ago, up until mid-November, a total of over 11 million people in Ontario were fully vaccinated. Of those individuals, so of those 11 million individuals, 17,000 became breakthrough cases, i.e. fully vaccinated individuals with full protection who became cases. Now, of course, of note is, between December and May of 2021, we did not have a lot of people fully vaccinated. So waves 2 and wave 3, we probably didn't have as many people protected, obviously. At this point in time, unvaccinated cases account for a vast majority, 91% of COVID cases since December, breakthrough cases accounting for only 3.8%. Similarly, unvaccinated cases account for 90% of hospitalizations, 90% of deaths, and breakthrough cases only accounting for about 2 to 3% of either one of those situations. The difference between the 90% and the 2, you'll note, obviously, there's still some unaccounted deaths and hospitalizations. That's from partially protected individuals. And we see this in some of these graphs where you look at the proportion of confirmed COVID-19 cases in this line, hospitalizations in this bar, and death in this bar. The blue represents breakthrough cases, the yellow partially vaccinated cases, and the gray unvaccinated cases. So across the board, unvaccinated cases have certainly made up a majority of the outcome in all 3 of these different outcomes. But of course, the denominator is changing. And over time, as the population becomes more highly vaccinated, the number of post-vaccinated cases will increase. And we're seeing that here in local data, like our proportion of cases associated who are fully vaccinated is proportionally increasing, but that's because the denominator is so much larger. So even with a highly effective vaccine, which we do have, cases may occur amongst vaccinated individuals due to a larger proportion of the population being vaccinated than unvaccinated. Which is why we always have to talk about rates. When we look at rates, though, the story doesn't change. Higher rates of everything COVID-related are being seen in unvaccinated individuals. The rate of COVID-19 in unvaccinated individuals continues to be higher compared to fully vaccinated individuals, and that's a trend that's consistent over time. In the past 30 days in Ontario, unvaccinated individuals were approximately 4.8 times more likely to become a case of COVID-19 compared to fully vaccinated individuals. And in the past 30 days, the rate of COVID-19 in unvaccinated individuals was higher compared to fully vaccinated individuals in every single age group. This looks at the 7-day average of COVID-19 cases per 100,000 person days amongst unvaccinated versus fully vaccinated individuals by symptom onset date. The black line represents unvaccinated cases, the blue line, breakthrough cases. And again, remarkable. The 4th wave was almost exclusively one of unvaccinated cases. It's waned a little and now is taking off. This dips at the end because this is based on an episode date. This will normalize in time. But again, the rate of symptomatic COVID-19 remains notably higher in unvaccinated individuals relative to fully vaccinated individuals. And that's seen across the age breakdowns. So a gray bar is unvaccinated rates, the blue bar is fully vaccinated rates, and obviously you see a dramatic difference consistent across all age groups. This is looking at hospitalizations, a very, very, very similar story, but even more pronounced, where the rate amongst unvaccinated individuals for hospitalizations is significantly higher than it is for breakthrough or fully vaccinated individuals who become ill with COVID-19. Hospitalizations, again, a very similar thing right across the age groups. In older age categories, 80 plus, individuals who are fully vaccinated are obviously more likely than somebody who's fully vaccinated in the 50 to 59 group to end up in hospital. But again, that's because of obviously comorbidities and other complications. And of course, fatalities as well. The fatalities we are seeing are still amongst the older population, even if vaccinated, but again, it is higher amongst unvaccinated cases across the province. All of that, of course, what about Omicron? I just put this in there just to note that obviously we're watching how this data can change globally with the onset of Omicron, which is going to become probably the predominant strain at some point in time in Ontario and in Canada, just a question of when. What we don't know about Omicron at this point is the impact of the vaccine on Omicron relative to Delta and previous strains. You'll hear lots of speculation out there. Obviously, there's lots of mutations within the Omicron strain that are causing concern, but quite frankly, there's not evidence to date on terms of exactly what the effectiveness of the vaccine will be. So I don't have answers on this one. That is obviously one of the more pressing questions. So we will continue to monitor that closely. All right. With that, I'm going to give you a quick highlight of COVID-19 vaccine for children 5 to 11. Obviously, Michelle is going to build on all this. And Michelle, if there's stuff that I'm going over that you want to save for your presentation, just jump in and say, hey, Summers, move it along, because I will talk certainly about specific needs here in Middlesex-London as well. The reasons to vaccinate kids are fairly self-evident, but it's helpful to see them written out, I find. This is kind of the key points that are being emphasized by the provincial government and Massey, and I agree with all of them. The vaccine's effective with a personal risk reduction of symptomatic COVID-19 of 91% less than those without the vaccine. So it works just like it's worked for the adult population. The vaccine is safe. Severe adverse events through the phase 2 and 3 trials were very, very rare. Talk about that briefly. There's a decreased personal risk of missing school, increased confidence in school safety. That really matters. We're already seeing that in high schools where our estimated vaccine coverage in our region is well north of 90% amongst attendees, or at least that age group anyways. And we're not seeing school exclusions as a result. Decreased risk of complications from COVID-19, including long COVID symptoms, hospitalizations, MISC, etc. Less impact on families, including less potential burden for isolation and testing, which I think we can all see from families in our lives. So it's a hard burden to bear. And then, of course, an increase for travel, enjoying social activities, etc. So lots and lots of reasons to get vaccinated for 5 to 11-year-olds. And the key messages from all of this is that the wide use of an effective vaccine reduces the public health burden of COVID-19 in children 5 to 11. Since September, in Middlesex-London and across the province, infection rates in school-age children have been steadily increasing. And certainly, as I've mentioned before, given the infectiousness of Delta and certainly the appearing infectiousness of Omicron, most children in this age group will ultimately be infected. We're getting to the point where by the spring, most people, if not vaccinated, will likely have been infected with COVID-19. Direct vaccination benefits for children include obviously the risks of acute COVID-19, risk of MISC and other post-COVID conditions, and that it also, of course, disrupts those adverse mental and physical collateral harms. There's also the key message that the benefits of vaccinating children outweigh the potential harms and risks. Clinical trials show it to be safe. We'll go through those details in a second. The risk of rare events is low. The vaccine safety system is robust, and that there's ways to make vaccination as easy as possible for kids. The card system, which I haven't gone into detail yet in any of our webinars, but really the card system is a way of facilitating encouragement and distraction to mitigate the discomfort of vaccination for kids. Some quick notes on the formulation themselves. Remarkably, the pediatric dose, the pediatric formulation, is actually more operational because of longer stability after unfreezing and more doses in each vial. So the pediatric sample comes in an orange top, the adult in a purple top. The dose for the pediatric dose is 10 micrograms, 10 doses per vial. The cool thing is that once it's diluted, it's stable at room temperature for 12 hours as opposed to 6 for the adult. So some notable differences there. The other thing is that once it's moved to the fridge, it can be in the fridge for 10 weeks as opposed to 31 days. And at room temperature, post-dilution, at room temperature, it's good for 24 hours, 12 hours following dilution. So again, a bit of a more operationally functional vaccine, which is very cool to see. There are a few vaccine ingredient differences, and I won't get into the nitty-gritty on this, but the pediatric dose has polyethylene glycol and trimethamine, or tris. So the modified formulation for pediatric doses uses a tris buffer instead of a phosphate buffered saline and excludes sodium and potassium chloride. What does this meaningfully mean? Not much of anything. The trimethamine is the compound found in contrast dyes, etc. But again, true allergies to tris are exceptionally rare. And there are ways that we can get around it through allergist assessment. Just a quick highlight on the clinical trials for those of you who haven't seen this before. The clinical trials through Pfizer were randomized, double-blind, placebo-controlled phase 1, 2, and 3 pediatric trials that studied 2 10 microgram doses at 21-day intervals with participants from the US, Finland, Poland, and Spain. Included pediatric participants with a history of prior SARS-CoV-2 infection or clinical symptoms, signs of COVID, children with known HIV, Hep B, Hep C, or stable pre-existing conditions, stably split between males and females. The median age of vaccination was 8. And the participants were randomized to an intervention, i.e. the vaccine, or a placebo, with a minimum safety follow-up of 2 months post-second dose. There was an additional safety cohort where the median duration of safety follow-up was 2.4 weeks post-second dose. So again, well studied with regards to its cohorts. The endpoints that they...
If you're going to present that, the results, I have that too, so I don't know.
Oh, perfect. Then I will wait. Michelle, it's going to be much better coming from you. So I will skip through the trial because Michelle is going to show it off, which is great. I'm going to skip through that very quickly, and I'm sure we'll get into that. I just want to highlight quickly on eligibility, and then we'll talk about what's happening here locally. Thanks, Michelle, for jumping in. So just quickly, eligibility, and this is from NACI. Just quickly, children 5 to 11 or turning 5 in 2021 are eligible to receive the vaccine. So for clarity, I think you guys have heard this already. Anyone born in 2016 or earlier is eligible to receive the vaccine. The province is still determining what the plan will be for the 2017 cohort as of January 1st, 2022. So obviously the kids right now who are turning 5 before the end of the year are like 4 years and 11 months old. It's a different story come January where we're going to have kids that are 4 years and 1 month old, and that might be a notable difference. So the province is still kind of determining in consultation with lots of people about what to do come January. But for the time being, anybody turning 5 in 2021 is eligible to receive the vaccine. The dosing interval, in contrast, seen in the Pfizer study, is at 8 weeks. It's a notable benefit of doing it at 8 weeks. It reduces the risk of myocarditis and pericarditis, or it appears to anyways. And the results certainly appear to suggest a more robust and durable immune response across all age brackets. We are now using an 8-week interval for everybody. So if you've got a 45-year-old that's coming in for a first dose, we're doing the 8-week interval. Obviously, if we end up in a very horrible big peak Omicron wave, we may have to reduce that shortened interval. But at this point, I think we're really going to try and hold out for the 8-week interval. The other thing to note is that children turning 12 between their first and second dose have been considered. Kids under 12 should receive the pediatric 10 microgram vaccine for their first dose. Adolescents 12 years of age and older should continue to receive 30 micrograms. Kids who are receiving the 10 microgram Pfizer vaccine for their first dose and then subsequently turn 12 can get the 30 microgram dose to complete their primary series. So you can just adjust the dosing depending on what age they are at the time of administration. At the end of the day, if they get 2 doses of 10 micrograms, it's not the end of the world, still considered valid. The other thing to note is obviously we've got some kids who were turning 11 this year, who got the 30 microgram Pfizer dose prior to the approval of the pediatric formulation in Canada. Again, those kids can complete the vaccine series with the product authorized for their age at the time of their second dose. So either 10 micrograms if still 11, 30 micrograms at 12 years. So we're keeping that nice and simple, I hope. about the concurrent administration of other vaccines. So unlike the adolescent and adult populations, the COVID vaccine for children 5 to 11 should not routinely be given concomitantly, or i.e. the same day, with other vaccines at this time. It's prudent, so say NACI, to wait for a period of at least 14 days before or after the administration of another vaccine before administering the COVID-19 vaccine. This is in contrast to where we currently are at with adolescents and adults, where you can give it at the same time the next day, the day before. The reason for this is to observe for APHEs, adverse events following immunization, and prevent erroneous attribution of an APHE to one particular vaccine over another. We just want to be able, through our APHE reporting system, to make sure that we're tracking the correct APHEs relative to the correct vaccine. Once we get more comfortable with what the APHEs are, then we will be able, I think, to move to concurrent administration of these vaccines. All that being said, if you have a patient who asks questions or comes to you and there is concern that if you don't get them for flu now, or you don't get them for one of the other vaccines now, and they're also going for COVID vaccine, prioritize getting them vaccinated. It's not really a safety concern. It's not a immunogenicity concern. It's really about APHE observations and surveillance. So truly, in one-off basis, it's not the end of the world if we're doing concurrent administration. Kids with previous COVID-19 infection should be vaccinated and can be offered 2 doses as long as their symptoms of acute illness have resolved and the kid's no longer infectious, which means they're out of isolation. Kids with a history of MIS-C may be vaccinated as well. It's been suggested 90 days since diagnosis or once they've recovered, whichever is longer. So just a little bit of a longer period for MIS-C kids. So that's vaccination in a nutshell. And we're going to hear more about the pediatric trials. Very excited to hear from Michelle on that. Just a quick update on vaccination here in Middlesex-London. So as of end of day Saturday, 90.2% of those 12 and older have received at least 1 dose, 87.5% are fully vaccinated. That is just an unbelievable accomplishment. It really shows, A, that we've got a community that loves vaccine, and B, that the policies and the approaches that have been taken, I think, have really made a difference, to say the least. So really encouraging. We've actually seen a slight uptake in 12 and olders who are getting a first dose. And I think that's probably because we've got some parents showing up with their 5 to 11-year-olds who are getting their first dose as well. Whatever brings them in, we'll take it. The dashboard on the Middlesex-London Health Unit gets updated every Tuesday with the updated data from the Saturday night, the weekend before. You can now toggle between the data for population age 12 and older and the population age 5 and older. So you can toggle between the 2 of those. My dog is getting somewhat excited, apologies. The other update to the dashboard is that the percent of MLHU residents by age groups now includes the 5 to 11-year-olds. You'll note that we've only got 4.8% with a single dose, and that's because this is from Saturday and we were only vaccinating Friday and Saturday. So this week will be a big week for increasing the lines on the 5 to 11-year-olds down here. We are also looking at booster doses in this graph now. That's that gray bar. So the 3rd dose is captured in the gray bar now. Obviously, we don't have a lot of people who've taken the 3rd dose. Most people aren't eligible at this point, but we'll be monitoring that a little bit more over time. I do think that the Omicron news will potentially both result in some people who are currently eligible moving ahead and getting vaccinated for a booster dose, as well as potentially expanded expanded eligibility for additional age groups. Just quickly, in the Middlesex-London region, in terms of sites for vaccination for both boosters and for kids, we've got mass vaccination sites. Those are MLHU runs. We've got some pop-up clinics, MLHU run pharmacies, and primary care. For the mass vax clinics, kids and anybody, booster doses as well, can continue to book appointments at covidvaccineln.ca. We also have a booking line 226-289-3560. If you have people that have problems with their vaccine receipts, they can also call this line. We've also got lots of people asking if they've got kids, multiple kids in their same household, how do they book appointments at the same time? You do have to book the appointment twice, and right now there's enough availability that I think people should be able to book in the same order. All that being said, as long as people book on the same day, if you show up, we will see both kids at the same Agriplex and Caradoc Community Center are our mass vaccination clinic sites at the moment. We've certainly worked to make it an enhanced pediatric experience. Western Fair is operating 5 days a week. Caradoc Community Center will be ramping up a little bit more as we move into expanded boosters. We also announced today, starting tomorrow at Masonville Mall, we'll have a walk-in pop-up clinic running from December 1st to December 31st, 5 days a week from Wednesday to Sunday, in order to provide walk-in opportunities for all types of doses. So this isn't just for kids, it's for adults too. We're just offering Pfizer. So we'll hopefully see quite a bit of people through this. And we're looking at more mobile opportunities for January and beyond. We really had to pivot a lot of our MLHU resources to support our mass vaccination efforts. So we don't have a lot of mobile clinics happening at the moment. We're doing some select school visits, but really it will be mass vax for the next little while. And then in January onwards, we'll start to shift towards more of our outreach work. You'll remember a similar pattern back in the beginning of the vaccination campaign. Obviously, this is a bit different because we actually have supplies. Back when we were starting off the vaccination campaign for adults, we didn't have supplies. So we had to make some decisions based on that. We have supplies now. So it's really a staffing that's the limitation in terms of getting outreach, but hopefully there'll be lots of availability as well through pharmacies. So not just locations here, but pharmacies as well will have lots of options. Speaking of pharmacies, for your patients that are trying, or if you were trying to find locations, if you just Google COVID-19 Vaccine Pharmacy Ontario, they'll take you to this website, COVID-19 Pharmacy Vaccine Locations, and you can enter in your postal code. It'll help list all the pharmacies in your area that are providing vaccine. So lots and lots of sites in our region, and pharmacies are going to be continuing to offer a substantial number of vaccines, particularly on the booster side, I think. So lots of rollout through pharmacies. The other stream is primary care, and this is just a quick plug. Those of you who attended the Tuesday webinar earlier today will have heard this already, so I'll be brief. But the COVID-19 vaccine distribution program from MLHU is up and running. And so if you're already signed up, tremendous. If you haven't, please consider doing so. If you have patients of any age, and particularly those 5 to 17, many parents, as we know, may feel more comfortable coming to see you as opposed to one of our mass vacs. And so we would certainly invite your registration in this. We have tried to update the program to make it as easy as possible for you. We recognize that COVAX isn't always the easiest thing, and the fact that it's not integrated with your EMR isn't perfect. Unfortunately, can't control that part yet. I know the province is mindful of this. We know that there's other limitations to vaccinating right now. For your awareness, I meet regularly with LMPCA leadership on this, and they've been tremendously helpful in providing context around what's working, what's not. And we do try to feed this up to the province so that they understand what limitations there are right now and how there's lots of other things on the plate. All that being said, we have tried to update the onboarding program to make it as painless as possible, including a streamlined and condensed training process, now 2 hours per staff as opposed to what was longer than that. We have enhanced informatics support, including a helpline to help navigate COVAX. We've reduced inventory reporting. We've tried to make the vaccine ordering process as efficient as possible, as well as provide lots of access to public health nurses to answer all vaccine-related questions should you have them. If you're interested, or if you have questions, please email covidvaccine.deployment@mlhu.on.ca if you have any interest, questions, or concerns. And then just a quick friendly reminder, and I recognize that some of you may be looking at this survey and going, Alex, I don't know what to tell you. Fine, very fair. We are just trying to get a loose sense of what potential delivery numbers may be available. This is just an expectation-free survey because it gives us some numbers that we can loosely plan around, because it helps us figure out how much mass vax capacity we need to have. So if you are planning to administer COVID vaccine to either kids or through those boosters between December and March, please let us know. It just helps us, again, figure out exactly what we need to be essentially budgeting capacity for. Lastly, if you're looking for additional information on COVID-19 vaccination for kids, or if you're trying to direct your patient to good data and information for kids, send them to our website, Children, Youth, and the COVID-19 Vaccine. It's also links to booking your appointments, so please send them our way. Your parents may also be interested in an Instagram Live event this coming Friday. Rod Lim and I from the Children's Hospital are doing an Instagram Live, which is always kind of surreal that we get to do those, kind of fun. So that's also available. All right, I think I've covered everything, and I think I did it within the appropriate amount of time, so I'm feeling good about that. Thanks so much, Vineet, and to the LMPCA team, Natalie, for hosting us, and I'll pass things over to you.
Thanks, Alex. Thanks. Yeah, you definitely covered a lot of ground there, and as always, a ton of great information. I'll just hand it over to Natalie to introduce our next speaker.
Sure. So Dr. Michelle Barton Forbes is Division Chief of Infectious Diseases at the Children's Hospital at LHSC. She sits on several national and regional committees involved in developing guidelines for the management and prevention of COVID-19 in Canadian children. In her clinical role, she's actively involved in the management and prevention of COVID-19 in children in Southwest Ontario, such as the initiatives such as the region's only pediatric COVID-19 virtual clinic and the special vaccine clinic that supports parents and children in decision-making around COVID-19 vaccine. And she's also involved in multiple multi-center studies, including studies on COVID-19 natural and vaccine immune response in marginalized populations. So welcome to Dr. Barton Forbes.
Thank you. Thanks for having me. Alex has covered quite a bit of the talks. I think I'll skip over a few slides that we can get to the questions. Anything that Alex has done, I'll just skip over. So today, I mean, we know Alex has established that, you know, it's essential to vaccinate the kids. But the question is, what is the impact of COVID-19 on children? And I think when we look at the impact, we need to look at the acute morbidity, and then we need to look at the later morbidity as it relates to MIS-C and long COVID, as well as indirect effects. So there's no doubt that children get infected. At the beginning of the pandemic, people thought that children didn't get infected simply because a lot of them were either mildly symptomatic or asymptomatic. But the bottom line is the data that we have shows us that children get affected, and this data is kind of stale because it's up to June 30th, the COVID experience in Ontario, and we see that 12.8% of the infected folks were children under 18 years of age. And teasing this out a little bit more specific to the 5 to 11-year-old, we see that they account for about 50 or just over 50% of the childhood infections. And then in terms of mortality and morbidity, this is where pediatrics got forgotten because they weren't seeing children getting hospitalized or going into ICU. For the most part, people thought that the children were not being affected, but they were the silent victims in this pandemic initially, and we now know more. So in terms of the hospitalization, yes, less than 1% of children overall get admitted. It might get a little higher, going towards 2% in the very young children. We also see that ICU admissions are rare, meaning 0.1%. But when you tease out the ICU admissions by age, you will see that the age group of interest, granted, this is not divided by 5 to 11, the groups are slightly different, but you can see that almost 20% of the ICU, the ones who end up in ICU, of the hospitalizations are 20%. In other words, when children get admitted, 1/5 of those who are in the age group 9 to 13 will end up in ICU. So this is the only published Canadian data on the pediatric COVID experience, and it was done through the Canadian Pediatrics Surveillance project, basically. And this looks at between April 2020 and December 2020, they had 264 pediatric inpatients. But really, as you know, a lot of patients get admitted for other reasons and are found to have incidental COVID. So when they took out those incidental COVIDs, they had 150 who truly had admissions for COVID-19. And you can see that similar to the Ontario data I showed you, you can see that the school-age children 6 to 12 accounted for, when you look at severe, when you look at the kids who truly had COVID-related infections, admissions for that, that's the last two columns. When you look at severe versus non-severe disease, 25% of the, that is 1 in 4 of the admissions for COVID in the 6 to 12-year-old end up in ICU. And then when you look at this a little bit more, when you look at all the ICU admissions, you see that 70% of children, if you go by age group, 70% of children who are admitted to hospital and are age 6 to 12, 70% of them will end up in ICU. So that's quite, you see that that age group is not insignificant, the morbidity, if they get to the point that they're severe disease or get to the point that they're hospitalized, 70% of them will have severe disease, which is much lower than the infant rate. So this is our group. We have, as a part of the Association for Medical Microbiologists and Infectious Disease Specialists, we have a pediatric arm, the PICNIC, and we basically have a cohort of children right across 17 centers. We also have data from 2 centers outside of Canada, in the Middle East and in Costa Rica. So I'm just using this data to kind of give you a sense of the risk factors in the multivariate analysis. So you can see that the key risk factors that we found were obesity, anemia, hemoglobinopathy. Neurological disorders came out quite, that's an important group. We also found that children who had bacterial or viral co-infections tended to do worse. And then of course, if they had MISC. In terms of the US data, they, interestingly, as it relates to other risk factors, they point out clearly that amongst their admissions, 32% of their children who were admitted didn't have any underlying conditions. And they picked up a racial, that racialized groups were affected, Blacks and non-Hispanics, Hispanics. So we've dealt with acute mortality, morbidity. Fortunately, we don't have much mortality. So acute morbidity in Canada, the rate is 0.003% for mortality. And I think those were just few related to MISC. So this is the MISC, as you know, multi-inflammatory syndrome in children, which is really an inflammatory condition, an immune dysregulation that occurs after COVID, anywhere from 2 to 4 weeks, this says, but we've seen it even to 6 weeks, and some persons extend that to 6 weeks. So it's a multi-organ dysfunction, and children can get quite sick. They usually have to be hospitalized, and a lot of them end up in ICU. This is the US data. You can see that 1% of their patients ended up dying. Okay, so long COVID. So data is still emerging, and the understanding is still not clear for children. It was initially thought that long COVID only affected adults, but we do know that over time, we are beginning to see children with a spectrum of symptoms. So in terms of the Pediatric Data, the Italians actually published quite a bit on that. And what we have seen is that the main symptoms that the children manifest, so we're talking about a syndrome that occurs after 12 weeks, with symptoms extending beyond 12 weeks from diagnosis of COVID. And in adults, you talk about the brain fog, you talk about headache and fatigue as the key ones, and some insomnia. In children, again, it is headache. Well, I don't know why my thing is jumping, but yeah, in children, it is headache, the loss of taste, and fatigue that are being described quite a bit. That's what was shown in the Italian group. In terms of other symptoms, it's hard to define what the symptoms are in younger children, especially the ones who are not speaking. But what's concerning about long COVID is that it affects, it will occur regardless of whether the child was symptomatic or not. So asymptomatic infection will become quite a challenge in terms of, you thought the child made it through COVID, but then they end up with issues. So nobody knows the exact rates. The rates have been described from anywhere from 2% to 10% in most, but there are a few that quote up to 20%. We don't know, and we are now beginning to collect data across the country as it relates to long COVID in children. So stay tuned. But it is quite distressing. We saw, what is even more distressing is the tinnitus. So you're seeing adults complain of tinnitus, but we're now beginning to see adolescents complaining of tinnitus, and it drives them crazy. So this is really a frustrating condition because there's not much that you can do. It's supportive management, and if you can prevent it, it would be much better. And then, of course, the other concern is the long-term effects of COVID on the brain, because MRI changes have been described in long COVID. And the question is, with growing children, what will that, what sort of impact will that have on their educational long-term outcome and stuff? So these are things that still we don't know enough, and we have to stay tuned. So then there are other impacts, of course, on their mental health, their education, social development, physical fitness, you name it, you've seen it. I think I don't have to convince you. We have enough of the indirect. And the unfortunate thing is that these are the things that are hard to measure, but these are probably the bigger burden of impact on the children. So if you're to do a cost benefit or a risk benefit analysis, it's hard to tease out. It's hard to tease out this aspect of the impact. And then, of course, Sick Kids published that over 70% of these children reported worse mental health during the initial COVID-19 lockdowns. Mental health impact has been well described. There are multiple papers. There's no question about that. And then, of course, there's one more thing, the orphanhood, the hidden pandemic. So these studies are a nice study for you to look at, but it basically looks across countries at the ratio of for every death of an adult that occurs, how many children are left without a parent or left without both parents. And you can, when you look at the data from this study, you see that in the developing world, you could have one death leave 5 orphans behind, 3 to 5 in a lot of the African and Indian countries. So that's going to have a huge impact on the growing child to come. So we will not even begin to capture the impact of COVID on children just in the short range. There's going to be lots more. Yeah. So this is it. So this shows you different countries and the ratio of loss. And you see in Malawi, you're talking about more than 3 for a male that dies. That's blue. Blue is male, pink is red, pink is female. For 1 male that dies, you have 4 children left orphaned. It's really quite sad. So the bottom line is COVID-19 can have huge impacts. Alex dealt with this already, so I'll skip over. So, and he gave you the introduction to the trials. So this is the data. It's an FDA slide showing the data looking at children ages 5 to 11 compared to those 16 to 25. And you can see that the study tried to, you know, to capture other races. The Hispanics and the Blacks were captured to a certain extent. And they also allowed some comorbidity in the group, so 20%. And we see that from the data, the big question was whether if they drop the dose to 10, which is a third, so they did different doses, and they wanted to take it down to as low a dose that would give equivalent antibody responses, and they were able to find that at the 10, you know, it was a non-inferiority trial, and they found that it was equivalent. And then in terms of efficacy, you can see, and Alex mentioned this already, that it's really quite efficacious. It matches the experience that we've had in the in the adults, which is around about 94%, the adolescents 100%, but anything over 90% is great. The vaccine is quite reactogenic. We know that in the adults, it causes sore arm and all these other symptoms. Fortunately, in children, apart from the sore arm, you can see the sore arm was there for the 5 to 11, 71%, matching the same. But you can see all the other symptoms, the fatigue and the headache and all those were much lower in the 5 to 11-year-olds compared to 16 to 25. So not as reactogenic in the younger children if you take out the sore arm. So what about myocarditis? So I'm not going to dwell on this. You know about myocarditis from the adolescents, but just because you will be counseling the parents, and that I'm finding that that's what the parents are hesitant about. They're thinking that young children have less disease than the adolescents because they've looked, some of the parents say, well, we see that the data shows that it's the adolescents who get sick and get into ICU. So why should we give our children who are having asymptomatic or mild disease? And we think myocarditis is a concern. So in terms of myocarditis, I just want to make the point that the bottom line is that we know we have a track record from the older children of what the worst scenario is. And the worst scenario is not all that bad because it's a 1 in 10,000 to 1 in 100,000 chance of myocarditis in the older child. However, we are reassured that myocarditis is probably going to be less likely in the, we are predicting, but we can't be 100% sure. Obviously, we're going to have to follow this out to see what, how it behaves. But there are things that reassure us. 1, the dose is a third less. 2, we know just from the natural epidemiology of myocarditis that viral myocarditis is more common in the adolescents. And we also saw from the post-vaccine myocarditis in our adolescents and young adults that it was males more than females. So, you know, there are now studies that have shown that that this might actually be linked to the androgens. And since young children are pre-pubertal, they won't have that hormonal influence. So these are factors that we think may help to make this less likely. But if we're wrong and it's just as bad, we've seen what it is like. Most children recover without any consequences. So I think we can give some sort of reassurance, but the bigger reassurance is that our system, our vaccine surveillance system, is excellent, and we continue to watch carefully. If you note, NACI made a different recommendation from the AAP, in that the AAP went ahead with dosing every 21 days, whereas NACI decided to stretch the doses to 2 months out to be able to reduce that excess immune response. So there are multiple factors that are interplaying that we think will likely reduce. Now, somebody asked, what about vaccine-related MISC? Well, we will be watching for that, but we have no reason to believe that if it happens, it will be at a high rate. So time will tell, and we will watch. And the good thing is that we know that when you look at the big picture of all the benefits, based on what I've spent some time talking to you about, you can see that, one, the vaccine will reduce the likelihood of serious disease. We already know that. It's shown, Alex showed you all those slides of the impact of immunization on the waves and stuff. So yes, it will reduce serious disease and ICU admissions. It will help us to reduce the chances of long COVID and MISC in our children, and get them back to what they want to do in terms of their school activity and extracurricular. And it will keep them healthy because they will be exercising and not locked up at home. And then as well, the spin-off for our community. The only children still account for a big chunk of unvaccinated of the unvaccinated population. And as you know, if we don't control COVID, it gives the COVID an opportunity to mutate, and we end up with variants of concern. So if we have more of our population immunized, then we stand a better chance of preventing future mutations. Of course, the big thing is getting the developing world to where we are. Then that's the only way that we can move forward. In terms of risks, we have no known risks from the trial, only the risks that we already knew from adolescents. So potential risks, extrapolating from our experience with the adolescents, would be allergy and myocarditis. But even with that, the benefits outweigh the known risks. So I just want to end with this last slide. And my question, this is a question that you need to ask your parents. Did they know that every time they jump in a car and take their child in a car, there's a 1% chance of a motor vehicle accident? But do they still go for the drive? Oh, yes. So that's a big question that you need to ask your parents when they're hesitant, and you would be surprised. So in summary, COVID-19 has had a huge impact on our children. The vaccine for kids is efficacious, and the benefits outweigh the risk. We need to get moving. Thank you.
Thank you so much, Dr. Barton. That was excellent talk, and really appreciate the Ontario local data as well as the global perspective. That was really helpful, I think, to put that in context. So thank you for that. So we'll move to questions for either presenter. So as we said before, feel free to put them in the chat, or if you'd like to unmute and ask. We don't have any questions yet, so I think we can accommodate either way. So does anyone want to raise their hand? You can also use the raise hand function on Zoom. That can be helpful. And we have somebody there. So, okay, go ahead. You can unmute yourself and ask your question.
Good afternoon. He is Kambiz Norozi. I'm a pediatric cardiologist. First of all, thank you, Michelle and Alex, for the great overview here, which is very important. And the question that I have is that you brought up the dose. We know in pediatric world that there are patients that we give the medication not because of the age, because of the weight. So what if, for example, I have a 12 years old patient that his weight is much more or less than 1 percentile, and then I have an 11 years old child with a weight which is 95 percentile. So what would be the decision for me to make? Shall I give you the adult dose or shall I give the child dose for those patients?
So hi, Kambiz, thank you. I can answer that question. So with vaccines, we don't go by weight. We've never gone by weight, we go by age. And so it really doesn't matter, we go by the age.
The reason I'm just asking the question, because this question comes often from my patients. So,
Right.
And I need kind of the argumentation that I can bring them, and it will be very helpful for myself also to convince them, you know what, that is, it doesn't matter.
Yeah, so that's what for flu vaccine, for all these vaccines, we don't stop to say, hey, what's the weight of the kid? The vaccine is based on the age.
I think ever so briefly, I think part of the explanation that we get this question a little bit too at the public health side of things, and at the simplest level, sometimes my explanation is, you know, the kid's immune system is this robust machine that's going to respond to whichever dose we give them. And so as we get closer to that 12-year-old age bracket, regardless of weight, that 10 microgram dose is still going to result in a robust immune response. So, you know, building on Michelle's points, you know, we've never administered vaccines based on weight. And certainly, you know, given what has been seen in the responsiveness across that 5 to 11 age bracket for the 10 microgram dose, still a profound immune response that we can be fairly confident in. So I've kind of framed it that way in talking to the general public, because we do get we've had some parents say, you know, my kid's, you know, 11 and a half, I'm going to wait until they're 12. And I emphasize it, do not wait at all to get the bigger dose for your child, get them vaccinated as quick as possible. This pediatric dose is going to do the trick.
And the trial data also showed you that there was no difference in terms of the antibody response using the 10 versus, so they did it at different doses and it didn't make a difference in terms of, yeah.
Thanks a lot.
Thanks very much for the talk, Dr. Barton Forbes. That was really interesting to see all the data there. I think what I just, one comment for then a question, I guess, was just that I just noticing like how well you made the argument that we need to be more urgent than maybe we've been acting when it comes to the pediatric population. I feel like we were really aggressive with the first doses for the adults and the age groups coming down, and now we're kind of finally got to that final age group, or that 5 to 11 year age group, and we're not as urgent as we should be, especially when we talk about all the you know, long COVID and the other risks that come with infection. So thanks for reminding us about that. Just one comment, just question about the MISC, like why like the rates were going up with cardiac involvement as the waves went on. Is there any like reason why that's happening? Or
we're wondering if it's a variant effect. If, in other words, is it that the Delta acts differently? So this needs some more teasing out and study, but definitely it's happening with the waves, and the wave change, as you know, the whole between the third and fourth wave, we got a big turnaround in terms of now it's all Delta, right? So we're not sure if it is the variant itself. Yeah.
Thank you.
You're welcome.
Thanks. I'm shocked that there are no questions coming through in the chat. I know a lot of them get answered on Tuesdays at noon with Alex's webinar, so that's great. All right, Dr. Clark, go ahead.
Yes, I'm just curious to ask about the next age group down, 6 months to 4 years. What do you think is happening with that? What do you think are going to be the concerns with that age group?
So, I mean, yeah, parents always get more anxious when the child gets younger. So I think the trials may be a little, they might take a bit longer because they probably will want to enroll more. Trials are already on the way, but in terms of data, that data isn't going to come right now, I don't think. I think it will be more towards next year.
Yeah, this late winter, spring is kind of the rumbles, but again, we don't know until we know. One thing I will note about that, it's likely the 2 to 4 year olds that'll be the next age bracket, and where that group will be vaccinated, I think, is an important question for us locally to start thinking about. I think the 5 to 11 year olds group is one group for pharmacies and mass vax. The 2 to 4 year olds is another group entirely. And so I think there will be, and again, planting the seeds to share with your LMPCA leadership, to help share with me and with others around what, when you imagine vaccinating as a community 2 to 4 year olds, what does that look like for us? What are the enablers that could help that happen? That is really helpful information for us to gather sooner than later, actually, because if the 5 to 11 year olds are any indication, before you know it, it's here. So thanks for asking that question, Julie.
A question in the chat from Tara Walker. What resources do you suggest for parents to look at online regarding the vaccine?
So CDC has some nice resources, as does AAP. CPS just published a statement, but it's more for pediatricians, although some parents have been reading it as well. Yeah, so definitely CDC and AAP has some good. Sick Kids has a nice handout on their site. Yeah.
Just tossed MLHU's website into the chat. It's targeted at the public, so targeted at parents and members of the general public who may have questions. So we've tried to break it down into questions that would be verbalized that way. So hopefully that's helpful.
One question maybe for you, Alex, although this is probably a provincial decision, but do you have any sense of whether the vaccine is going to be mandated for this age group for sports and activities? Because I know that's been a motivation that I've seen for.
Yeah, no, great question. And that actually, the provincial regulations went as far as 18, and then it's been essentially the collective will of the public health units to drop it to 12. We will evaluate, I'll speak for myself, like I'll be evaluating that over the course of the winter. Obviously with the 8-week interval, from a fairness perspective, obviously if the risk becomes profound, we'll act accordingly. But from a fairness perspective, we'll look towards, February into March is the earliest where we would be requiring vaccination to do something like that. And that will really depend on the epidemiology between now and then. I do think that the requirement for vaccination for 12 to 17 year olds was to do extracurricular activities like sports was significant in making the coverage rates as high as they were. So we'll explore that as time goes on. I do think we have to, I think there's a societal comfort that we have to have where there's, the vaccine's been out there for a while, people are comfortable. I will say the younger the children get, Michelle, you can probably attest to this in your frontline clinical experience, the younger they get, the more cautious people are about everything. And so, even the response, I've had people email and say, I was fine when you mandated it down to 12, but if you go down to 5, I will, raise all stink. Okay, so it's just a very interesting societal shift with regards to what's tolerated around some of that.
Yeah, and if you notice the language in CPS and NACI, it's may. It's not should, it's may.
Great. Question from Stephen Wetmore. Do you think town halls for parents will have any success at getting the hesitant on board? Would that be something to consider, Dr. Wetmore? What's the attendance? I guess just piggyback on that. I don't know, Alex, with the Instagram lives, what's the attendance been like from parents?
Yeah, so we've had Instagram Lives, like 80 people, give or take. It depends. We've done large town halls kind of based with the school boards and stuff like that, and we get like 30 people out of our population of 500,000. So I would say we've used them. It's variable sometimes in terms of attendance and participation. I think we found that, you know, the kind of broad communication has satisfied a little bit of that. Again, we'll review, as you know, right now we know we're dealing with the eager beavers and all of this, and we'll try and see where that lands. And I think our communication objective is to get through the first wave of people who, you know, would have gotten vaccinated come hell or high water, and then we'll probably restart some of this campaign to try and get down to the hesitant a little bit, kind of do it in waves. The nice thing about going back and doing some of this stuff later on is then we've got, you know, community momentum where we can say, you know, 50% of your peers have done this. Why have they done it? Let's talk about that. That's a helpful part of it.
Okay, great. Did you want to add something, Michelle?
I wanted to say that we also offer at the hospital for the parents who are really struggling with making a decision. We offer a vaccine clinic to help those hesitant parents, and the feedback has been good. They, you know, they feel like they feel definitely reassured, because you basically tease out what is the issue, why they are hesitant, what is the big issue, and then address that issue with the information that they need. And yeah, they have found it to be useful. So if you have patients that are really struggling, you can refer them to our clinic.
Great. Question from Dr. Schachter. Logistical question: should a 1-inch needle be used in the 5 to 11-year-olds, or should a smaller needle be used?
Sorry?
1-inch needle for 5 to 11s or smaller?
You can use a 1-inch needle as well for 5 to 11-year-olds.
And then for Dr. Vanderwall, when our staff called parents to think about bringing their children for vaccine at our office, the response was, I want to wait a bit more, even though the parent were told that Dr. So-and-so, your family doctor, is highly recommending this. How should our staff respond to that comment on the phone?
I think you have to figure out what it is and find out if they need more information. You might have to have resources available, or links that they can look up for themselves. Whenever somebody says they want to wait, it's telling you that they have a question that's not answered, a concern, and it's begging you to find out what the issue is. So maybe the staff, maybe it is that they need to book an appointment to talk to somebody. Yeah.
Just building on Michelle's point, I'm part of the community momentum I was referring to may be a helpful response as well. You know, indicating that, you know, I understand you may want to wait a bit more. You know, I would note, you know, 25% of your peers around our region are moving forward. So we're seeing kids vaccinated already and things are going well. And, you know, are you waiting for anything in particular? And kind of put the challenge out there, you know, what is it that you're waiting for? And they may or may not be able to verbalize that, but it will help with that conversation that Michelle is outlining of, you know, what is the question here? What are we waiting for? And if it's, you know, part of that, to Vinit's point, is also creating some urgency. You know, as we go into the winter and as we see case counts rising, you know, we are, who even knows, but we are not years away. We are months away from everybody who's not immunized getting COVID, right? Like this is a ticking clock with regards to when COVID is going to infect those that are unvaccinated, including those who are younger. So it's there is urgency here, and as Michelle has outlined in her presentation, it's not a benign illness at all.
Yeah, and the other thing to emphasize is that this COVID merging this winter is different from COVID last winter, because now we have co-infections. we have a nasty, what I would say is RSV has come back with a vengeance. It's rolled Montreal over. It's hitting Chio, Ottawa, and so it's just a matter of time before we start seeing even bigger numbers down here. And the data is clear that the risk for COVID in children increases, the risk for severity increases if there's co-infection. So the merge of infections, we've already seen it. We've already seen the merge of infections just this winter, and we know that the children get sicker.
Great, thank you. And I know, correct me if I'm wrong on this step, either of you, but what I've been telling parents too is that even though it's sort of rolling out here, I think there's close to 3 million kids in the US that have now received it in that age group, or over 2 million, I believe. Anyway, so the Americans did go ahead of us, and we'd expect it to be similar.
And so you can borrow information from their experience, because when we talk about rare vaccine events, we're saying we're looking for things that are happening 1 in 100,000, 1 in a million. So we can actually speak to the 100,000 now. If they've given 3 million doses, we can speak to the 100,000 now, at least for the first dose.
A comment from Dr. Clark. So I've heard from elementary teachers that there are not specific conversations or communications within the school about vaccination. I wonder why Thames Valley District School Board isn't partnering with MLHU to try to evangelize about vaccinating. Maybe the board is trying to avoid controversy with anti-vaxxers. Any comment, Alex? either you can comment on
that. These are ongoing discussions around how to communicate out broadly. The Thames Valley District School Board and London Catholic District School Board were certainly very helpful in facilitating messaging around vaccination for 12 to 17-year-olds. I think that did result in quite a bit of feedback, and I think that just needs to be navigated a bit more. So yes, Julie, it's very much on our radar, and you'll see a little bit more in the next little while on that.
Another comment from Dr. Price, single dose vials could help in primary care, easier for me than bulking people together. This way I can give them as they come and not worried as much about time expiration. So
yeah, it's been flagged for the pharmacy companies up and down the line around how this helps with opportunistic vaccination. And that is the name of the game. That's a Phil phrase that I really like, and I use all phrases from Phil I like, for the record, but opportunistic vaccination and single dose vials, single draw syringes, these are all, these reflect how vaccination is typically delivered in primary care. I think as we see these, even the multi-use vials have an extended shelf life for post dilution or post draw and all that type of stuff, that'll help. So I think this is going to evolve, but the barriers are many, including some of these logistical barriers. There's financial stuff, there's lots of things. We get it for sure.
Any further questions or comments before we wrap up?
Sorry, also one question for you. It's kind of more of a fun-ish kind of thing, but just having we're hearing bits and pieces about what's happening at the Agriplex as far as to make the process more friendly for kids, and just wondering if you could maybe share some of those things so that if I'm talking to that 6 or 7-year-old in the office and kind of make them feel more excited about it and less scared, kind of thing.
Yeah, for sure. So when kind of coming through the door, so when you show up, you as a kid or as an adult for that matter, you're actually guided through the facility with really colorful floor markers that have hot air balloons and colors and lots of stuff on it. So even from the moment you arrive, there's a pathway you can follow into the vaccination clinic. We then have these what are called look and find distraction tools. So they're laminated pieces of paper that have look and finds where it's a cityscape and you're looking to see what you can find. We've got these stress stars, which I don't have in my office at work, not here. These stress stars, they're yellow and red that kids can hold on to and squeeze. The actual vaccination pods that we're trying to use for a majority of kids have signs up on the wall and are colorfully dressed. So all that's in place. Obviously, mom and dad and guardian can be right there with you through that vaccination process. In the post-vaccination area, there's TVs with messaging that comes across. We don't have Paw Patrol on, although that was part of the discussion. So lots of colors, lots of distractions as necessary. And that really, I think, has made a difference. On your way out, you also get to take your picture with the vaccination superhero. That's on a big couple poster boards. So the selfies are all over my Twitter feed. I get added on all of them, which is delightful to say the least.
Nice.
It's awesome. It is awesome. It is awesome. Yeah, lots of those types of things in place, Vineet. So when you're talking to your families, again, like from the moment you enter to the moment you leave, it is as kind of kid friendly and kid inviting as we can manage given the environment. It does not feel, was there on Sunday, it does not feel to me like going into your classic hospital. It feels like going to a fair in a lot of ways. So kind of a cool experience that way. And we are working on getting therapy dogs, but no promise on how often they'll be there. But we're working on that. Apparently, Michelle, there's a pug that comes to the children's hospital every once in a while, and that's going to be one of our featured guests. So we'll see. So
what about clowns?
Yeah, no clowns as of yet. I think clowns, it's a bit of a coin toss as to whether or not that's helpful or not.
Bubbles? Any bubbles?
Well, everybody was like, you need to do bubbles. And I was like, guys, it's still a respiratory pandemic we're dealing with. People blowing bubbles in the mass vaccination clinic. And that seems wow.
That's great. And just actually for Dr. Barton, could you just mention how we refer to that clinic you mentioned, like the pediatric vaccine, I guess?
Oh, that's a referral to pediatric ID,
okay.
to the vaccine clinic.
Okay.
Pediatric ID. Yeah.
I have a quick question. 10-dose vials for kids. Sometimes we have 10 people lined up and 1 or 2 become really squeamish to the point where the parents say, well, we're not going to do it today. So obviously we're going to be left at some point with 2 doses or even 3 doses of a 10-dose vial where we can't give it in the time frame allotted. How bad is that? I mean, I feel terrible every time I waste a dose, but in the grand scheme of things, is it better to get the 7 vaccinated and have to waste a few, or is it just completely frowned upon?
No, it's better to get the doses in and to waste than to miss the opportunity. So similar to how we're approaching the adult doses. And I mean, I say that in the context, I think we all know the global context, and this is complicated. What can you do? But the priority is on first and second doses. And so as your note, if you got 10 lined up and for whatever reason you're down to 80%, so be it. So be it. Hopefully that provides some clarity. That is the official policy of the government. So this isn't deviating profoundly from anything in particular. It is unfortunate, and I think we all kind of recognize that this is complicated times, to say the least.
Another question, do you guys have stickers that you can hand out and give along with the needles?
Oh, I forgot about the stickers. Yes, we do. We have stickers.
I think you need to send them to family doctors' offices.
Sure. You know what? We should include them in the ordering process. I'll talk to the team about that. Yeah, we've got there's a different type of sticker for your first dose, and just to convince you to come back for your second dose, there's a different colored sticker for your second dose, which as a guy who does not have kids, I have been led to understand that that's a very important thing.
Absolutely.
Yeah, all over it. Just a quick note, there is obviously Michelle mentioned local resources for parents that want to have some conversations about vaccination. I just put in the chat, there's a Sick Kids COVID-19 vaccine consult service as well that they're offering for like e-appointments to talk with a healthcare provider about the COVID vaccine. So I just placed that in there. So there are certainly some resources out there.
And there is a resource as well that some people might not be aware about, the Children's Hospital for kids who have high levels of vaccine anxiety or needle phobia. We can send the link. I can send the link out as well, which is helpful. So, Rachel, I think we'll wrap up there unless anyone has any final questions or comments. Speak now. Okay, great. So Janet will send out the slides probably early next week for everyone that's attended. So anyone who is not signed up on the Southwest Primary Care Alliance email list, the link to that Janet posted earlier in the chat. So get on that list to get all the information. And thanks again to our speakers, Dr. Summers, Dr. Barton, and to everyone for coming, and Southwest Primary Care